huge problem. It's a huge problem in countries other than the United States, even worse than in the United States. So here's a little bit of the history of TB. This is for the United States. It has been making a re-entry back in the last 20 years with thousands and thousands of cases newly identified, newly diagnosed every single year. And as I mentioned, in other countries, much, much worse than this. Here's a nice comparison of deaths related to various reasons. You see tuberculosis on there. Notice that tuberculosis is now relatively low. The United States is shown at the top and globally is at the bottom. It used to be much higher than that as causes of death. Again, more statistics. By the way, that YouTube up at the top is a really good one if you want to look more at the status of TB in the United States. And more statistics. And from here, we're going to be talking about HIV at a later time. And HIV is very often related to TB. TB is a very common infection that people with AIDS get. So, let's go back to 1882. Robert Koch discovered the organism. He played around with trying to find a good stain for it. What you're looking at on the stain here is phlegm that has been coughed up from the lungs. The blue cells are just cells from the lungs, and the small, delicate, hot pink rods are Mycobacterium tuberculosis. Now, he did not perfect the acid-fast stain, but he was the first one to try his hand at it. Actually, somebody else came along with the final variation of it. This has been a problem for many, many, many years. It was particularly bad around the turn of the 20th century. Things took a little bit of a turn in the mid-1900s when we started to develop antibiotics for it. Some of the important things about this organism: it's a gram-positive rod, it is aerobic, it is acid-fast because it has mycolic acid in its wall, along with peptidoglycan. It's got a slow generation time. It takes hours and hours for it to double, so it's tedious to try to grow this in culture. You see some cultures of a couple of species on the right. Another unique thing about Mycobacterium is it will be phagocytosed, but it is not killed. It lives inside of vacuoles within phagocytic cells. It also induces a strong cellular immune response, cellular immunity. And I set this up earlier in the about 10-15 minutes ago in the video talking about delayed type hypersensitivity. You might want to go back and look at that again in this video. So here are some of the key things. Long incubation period, then infection. So let's say that you inhale the organism. Maybe the organism is in an aerosol from somebody coughing. Maybe you touch something that has the organism on it. Whatever way, it gets into the body. Now, let me go to this graphic. So here is the original infection at the top left, and you now have a primary tuberculosis infection. But this does not mean yet that you have tuberculosis. Two routes can be taken. Let's go with the route to the right. You're a 21-year-old healthy person. You've got a strong immune system. So the organism is now in the lungs, and it draws in white blood cells and immune cells, forming a wall around the bacteria so that the bacteria cannot spread. They are basically separated, sequestered, controlled within the lung tissue. Those structures in blue are called granulomas, may also be called tubercles. Now remember, you have a healthy immune system. You do not have an active TB infection. You have a dormant tuberculosis infection. You have no symptoms. You are not transmitting the infection. You may stay this way forever, and it may never be a problem again. Or maybe 50 years down the way, when you are 70 something, your immune system is now weaker, or maybe you're on drugs, you're an alcoholic, you have an underlying condition like diabetes. All of these will reduce the effectiveness of your immune system. And those tubercles with the bacteria that have not been destroyed now start increasing in number and break out of those tubercles, causing lung damage and may spread to other areas. That's called reactivation tuberculosis. It was dormant. It now reactivates. This is typically what you see in older people that were infected actually at a much younger age. But due to whatever problem in their body, they now get reactivation TB. That's scenario 1. You see over here that I have it under dormancy. Now, scenario 2. You start out as this 21-year-old person that you see over here, but let's say that this person is HIV positive, and they have dwindling numbers of T lymphocytes. And obviously that is going to affect certainly their cellular immunity, but also humoral immunity, because remember, T helper cells contact and activate B cells for humoral immunity. So, because they have a weak immune system to begin with, the organisms that they've inhaled just keep growing. They are not contained at all, or to very little extent. This is called progressive tuberculosis. Here's a look at age groups over a period of 25 years or so. You can see that the numbers have come down. Here's a comparison of the person with latent or dormant TB to the person with active TB. So the big takeaway that when you look at these is that the person with latent or dormant tuberculosis, if it has not been reactivated, they have no symptoms. They're not transmitting the organism. The person with active TB, yes, on both counts. So I mentioned it could spread to different areas. Here is a ruptured tubercle in the lung, and the bacteria can move to different areas of the lung, or they can be carried to other organs via blood. So on the right you see some x-rays, 2 x-rays showing you tubercles, and one color enhanced, and at the bottom you see an autopsy showing you lung with a tubercle. And again, there would be live bacteria in there. Symptoms. Let me first start out talking about the fact that not all tuberculosis has to involve the lungs. I just mentioned it can spread. So up at the top right, you see a kidney full of tubercles. The spinal column that you see at the bottom is from somebody who had spinal tuberculosis. And the woman up at the top, you see a tubercle in the neck, and at the bottom, you see 2 tubercles in the brain. Generally, you think of it as being respiratory and lung related. The symptomology, here it is listed. Kind of nondescript. There can be many things that have that symptomology, so obviously tests have to be done. The epidemiology is very interesting here. There are people that are at higher risk. Immigrants, again, coming from countries that may have much higher rates of TB than in the United States. Street people, people that are homeless, very often they're undernutritioned. They may be doing drugs. They may not be getting health care, obviously, so they have weaker immune systems, HIV positive, and healthcare workers, because you come in contact with these people, you being nurses, doctors, and so on. Other factors: lower socioeconomic status, SES. I've already mentioned immigrants, and ethnicity. This disease does not hit everybody equally. So look at Caucasians. You're looking at the prevalence rates of how many cases per 100,000 people. Now look at Asians and American Indians or Alaska natives, much higher. And another look for 2017. And just to look at numbers over time, I did want to point out that the numbers are dropping. You can see that. If you want to look at global tuberculosis, which is a really big problem, you probably want to go to the World Health Organization. Did want to point out that the states in blue make up most of the cases, or about 50%. And Texas, since we are here, I thought you'd want to know that. Diagnosis. Already mentioned the tuberculin skin test. You see it right there. It has to be checked at 48 to 72 hours. It has to be a certain size. You just can't have a tiny little red spot. It's got to be over 1 centimeter or 10 millimeters. So who would be positive? If you have active TB, if you have a latent infection, or you have been given a vaccine. We'll talk about that in a minute. So remember, just because you have a positive tuberculin skin test does not mean that you have active TB. To back it up, you can do x-rays, you can do molecular testing like PCR, you can do sputum lab culture, although that's kind of not even done anymore in the United States because it takes so long to do it. But let's jump over to immunological testing. The quantiferin test is the gold standard for tuberculosis diagnosis in a lab now. It basically has to do with the fact they are looking for increased amounts of interferon. Remember interferon? It's one of the cytokines. I've mentioned it a couple of times. And if you have been exposed to tuberculosis, you will have exaggerated amounts of gamma interferon when your cells are exposed to the Mycobacterium protein in a lab test. Treatment, not much to say. You're on treatment for a long time, which obviously makes it difficult to get street people in to be treated properly, because you have to take drugs every day. And there's also a big problem with drug resistance for tuberculosis. Last, I mentioned the vaccine. Let me just point it out one more time. There is a vaccine called the BCG, Bacille Calmette-Guerin. Calmette and Guerin were the two men that developed it. It's been used for a long time. It's made of attenuated, weakened Mycobacterium, but it's not Mycobacterium tuberculosis, it's Mycobacterium bovis, which comes from cows. I'll get back to that in a minute. We don't use it in the United States unless you are a nurse or a doctor working at a tuberculosis hospital, maybe. They may give it. But it's used a lot in some other countries, like all of the English ruled countries, or they were ruled by England, like Australia, New Zealand, India, Hong Kong, the UK. The reason why the US doesn't want to use the vaccine is that everybody who gets the vaccine would be positive, and then on the skin test, and you wouldn't be able to tell who's been exposed and who's not. So it basically makes that test worthless. So they'd rather treat case by case You might be thinking, well, I mean, if it's a great vaccine, then we wouldn't have a problem with TB. Why not give it? Well, there's a question about how good it is. The statistics can show anywhere from 70% to 90% efficiency, and the U.S. health system has decided that's just not a good enough coverage. I did want to mention Mycobacterium bovis, though, one more time. As you already know, I mentioned, you think of tuberculosis as being lung-related. But in many other countries, and it used to be the same way in the United States, you could get TB by ingestion, by contaminated dairy products. Because cows make milk, and that milk could have the tuberculosis bacteria in it, and therefore people that drank raw milk got tuberculosis that way. Of course, our milk is pasteurized. There is a new vaccine that's being developed now that should be better, made of the actual Mycobacterium tuberculosis species. It's not out yet. Don't know when that would be. And that's it for this video.